Wonderful to see you once again after our break. Apologies about that. So wonderful to welcome you all back this afternoon to our weekly Gecko session after our break last week. We have 80 registrations this session from 15 sub-Saharan countries, including the Maldives and the United Kingdom. So we dedicate the session today to pathology, and we're extending our interest from hepatic histopathology to the GI tract. And this afternoon, we begin the series of sessions concentrating on the luminal pathology of the upper GI tract. And it's really a great pleasure once again to welcome and invite Professor Martin Hale, our resident pathologist from WITS, to conduct this session. Martin, thanks again very much for your enthusiasm and all the time and dedication that you are giving us to these Gecko sessions. I think they're very well received, and we look forward to the session once again. Thank you, Martin.
So thanks very much, Chris, and welcome everybody, and thanks very much for asking me to participate. I certainly enjoy them and interacting with everybody. So we've got quite a full house this evening as far as cases are concerned. So I'm going to start off just by sharing a little bit of the histopathology with you. Can everybody see that screen?
Yeah.
So I was just why don't I can't see my as you said, technology. We were just chatting there. I need to show the full screen. I can't see it. Oh, why is that not closing? That's it. Okay, so there you've got the first slide. I just so I can see it. Great. Okay, so what I'm going to go through a number of cases. We're going to start off with the esophagus, move into the stomach, and then the duodenum. So Chris asked me just to go through some of the normal histopathological features. So what we're going to do is also with the help of Barbara is we're going to first of all look at the normal histology of the different parts of the upper GI tract. And then once we've done that, we'll then move to Barbara. Will give you a short potted history of a particular case, and then I'll show you the pathology of that particular place. Then there's the normal histology of the esophagus, and here, and I hope you can see the slide, at least the pointer. What we've got, this is actually a slide from the Armed Forces Institute of Pathology, and a very nicely orientated section. You can see the non-keratinizing squamous epithelium at the top, this very narrow basal layer of basaloid epithelial cells. And then here we've got a duct, which effectively leads into these mucus-secreting glands. Now, this is an unusual photograph, really, because it's not often we see this sort of pathology and histology in the normal esophagus, because these glands and ducts are fairly few and far between. But it does give you an idea as to what the normal histology looks like. So this is usually what we see, and this is a normal picture of an uninflamed normal esophagus. And if we start in this region here, we've got the submucosa there. We've got this very thin layer of basal epithelial cells, and these here are vascular papillae. And they are relatively evenly distributed, as one can see. And then the squamous epithelial cells, obviously this is the proliferation zone. where you get cell division taking place. And as the cells mature, so they move up through the epithelium, and you can see, for example, the evidence of maturation. If you look at the nuclei here, you can see that they are relatively large compared to the size of the cell. So we call that a large or an increased nuclear cytoplasmic ratio. In other words, the ratio of the nucleus to the cytoplasm is 1:1, or it may even be less. But as we progress through the mucosa, what happens is that the nucleus becomes smaller, and ultimately it starts to flatten out, and then finally it then exfoliates from the epithelium during the process of renewal. Before we move on, just to show you these spaces here, this represents clefting between the cells. Some of the cleared cytoplasm, in fact, is actually glycogen. So there's glycogen in these cells, and glycogen dissolves out when we process the tissue, particularly when we fix it in formalin fixative. What I want to do next is show you we're going to show a particular case, and I just want to go through the landmarks, the anatomical landmarks, and I think you will probably, as gastroenterologists, will know more about this than I do. But I really wanted to put this in, really to demonstrate to the histopathologists and the residents the important landmarks that we all know about in the esophagus. So there are a couple of them, and the first is the squamo-columnar junction, and also the gastroesophageal junction. Now, normally the gastroesophageal junction is the my pointer keeps on disappearing. The gastroesophageal junction marks the most proximal point of the gastric folds with the esophagus, and you see that there. And the squamo-columnar junction, as its name implies, is the junction between the squamous epithelium and the columnar mucosa. Now, ideally, the two junctions, in fact, should coincide. But often, in fact, what happens is that they become separated when the squamo-columnar junction becomes more proximately orientated compared to the gastroesophageal junction. And in fact, it's very important, particularly when one is looking at biopsies for suspected Barrett's esophagus, that we know where these biopsies have been taken. So it's from an endoscopy point of view, we certainly very much appreciate if you tell us exactly where your biopsy has been taken from. Now, the other thing that I want to do as well, because we are going to be talking a little bit about, excuse me, Barrett's esophagus, is something that is seldom used. In fact, it's seldom that I actually get this information myself. And that is the Prague criteria for assessing the extent of Barrett's esophagus. And simply put, it's a measurement of the circumference of the columnar change with the height of the columnar change. And that's basically called the circumference or the CNM criteria for Barrett's esophagus. And it's measured in centimeters. So as this diagram implies, the grading of this is C2M5. Okay, Barbara, do you want to carry on?
Just before Barbara, I just want to ask everyone who wants to ask a question. The chat is available for questions if you would post your questions. Thank you.
The case I'm presenting now is Mr. L, 55-year-old male from Benoni. He has a background history of GORD and NSAID use. He came in with a diagnosis of iron deficiency anemia. And on his scope, we found Barrett's esophagitis. And as Prof has mentioned, the Prague criteria was C 2 centimeters and M 4 centimeters.
Thanks, Barbara. Right, so you should see a full screen there of histology. Chris, if you could just confirm that, please.
Yeah, it's not a full screen, but it is a partial screen, but we can see it clearly, yeah.
Can you see it clearly?
Yeah.
It may be because you've got images of everybody else, no?
No.
Not.
Okay, no, but it's fine.
It's okay, okay.
Yeah.
But so what we've got here then are multiple portions of mucosa, which have been derived from the lower esophagus, and the as you've heard Barbara say, the clinical diagnosis or the endoscopic diagnosis was that of Barrett's esophagus. So here we've got a good example of benign squamous mucosa. You can see that there is a little bit of proliferation of the basal layer of the epithelium. So there is basal cell hypoplasia. And as you see and recognize from the previous histology, the normal histology, that the number of vascular papillae is increased. And if you look here, you can see that there is maturation of the mucosa. So that mucosa is fine from a squamous appearance. If we just saw this on its own, without the underlying changes in the submucosa, we would probably call this just a mild esophagitis, probably in keeping with the reflux picture. When we look at the underlying submucosa, though, what we see are these numerous intestinal type glands, and you can see this extensive goblet cell change. And this is typical of Barrett's esophagus. Now, what I would like to do before I go any further is show you what happens when you get goblet cell change. So this is a combined Alcium blue and PAS stain. And normally what happens when one has mucin in, I'm just trying to think of a good example. Let's say we have normal gastric mucins, then those would be PAS positive, and they would be magenta in color, such as this here. And you can see this reddish color, this magenta color, which is quite typical of what we call neutral mucins. But when you have intestinal metaplasia and you start to get goblet cell change, then what happens is that the mucins then change and they become acidic mucins. So this is a stain which is a combined Alcium blue stain with a periodic acid Schiff or PAS stain. And what this does, is demonstrate, in fact, that we've got two types of mucin. So the neutral mucins are staining up magenta, whereas the acidic mucins, indicating intestinal metaplasia, are staining up blue. So this is just a particular gland which I've shown you. You can see that there is varying expression of these goblet cells in these glands. If we now go to our portion of squamous mucosa, you can see there that, in fact, this is actually nicely demonstrated, because what we've got here is the squamous mucosa here, and you can see the magenta staining. And the reason it is staining magenta is because this is a PAS stain. It also picks up glycogen. So the glycogen is positive as well in the squamous epithelium. If you look in the underlying glands, you can see that those intestinal glands, in fact, show a combination of neutral mucin and also acidic mucin secondary to the intestinal metaplasia. So it's a very good example then of intestinal metaplasia that is occurring in a patient with Barrett's esophagus. Now, some of the other histopathological changes that we look for, and in fact, there need to be several. And one of the characteristics is what we call the multi-layered epithelium. And the multi-layered epithelium if you like. So from a histopathologist point of view, everybody knows or should know about squamous metaplasia that occurs in the cervix. And what happens there is that the endocervical epithelium, on the surface of that endocervical epithelium, so you get metaplastic change, it becomes squamous in type. And then in many instances, in fact, what happens is that you get a squamous epithelium overlying columnar epithelium, the columnar mucosa of the endocervix. And the multi-layered epithelium in the Barrett's esophagus is very similar. And in fact, multi-layered epithelium is actually quite characteristic of Barrett's esophagus, and it helps you confirm the diagnosis. And here, there is just a focus of that. And here, you can see, for example, on the surface, you've got these goblet cells. These are columnar cells. And then under here, you can see the remnants of the squamous epithelium from the squamous mucosa of the esophagus. And I'm very pleased because what you should be able to see is you can see the prickles. You see these intercellular bridges. You've all heard of the prickle cell layer in the skin and so on, which is a typical feature of squamous epithelium. And there you can see the prickles, which confirms the fact that this is squamous epithelium. So this is typical multi-layered epithelium, and with squamous epithelium at the base and the columnar mucosa at the surface. And that almost confirms the fact that we are dealing with Barrett's esophagus. Now, the other changes that happen, first of all, if we go under lower power, you can see that we've got the surface, and I'll be spending a little bit of time here, and you can see that we've got this intestinal metaplasia on the surface of the epithelium, and then underneath, these glands appear disorganized. You can see this budding of the glands. They're irregular in outline, irregular in shape, and also irregular in size. And those features are quite typical of Barrett's. So you don't get the normal regular orientation of the small bowel crypts. The other thing that you also get is between the glands, you get strips of smooth muscle or smooth muscle fascicles, as you can see there, and you also get increased collagenization. So you can see the smooth muscle, and it goes all the way up to the surface of the epithelium. And there, for example, I think you can see that there are smooth muscle fascicles right at the surface of the epithelium. Now, the most important thing that we have to assess, obviously, is for dysplasia. And dysplasia, the literature is quite sort of varied, and it changes from time to time. And I think the current thoughts are that when you want to call something dysplastic, you should see dysplasia in the superficial columnar epithelium. So here we've got superficial columnar epithelium. And if you look at this columnar epithelium, you can see that it is well orientated. We call this, it's what we call retaining the polarity. In other words, the nuclei are lining up all next to each other in an orderly fashion. When the epithelium becomes dysplastic, it becomes multi-layered. Now, here you've got the epithelium, which is lined up in a uniform manner, whereas here it appears a little bit more stratified. And the reason why this appears stratified is because of the tangential nature of the sectioning of that particular part of the epithelium. So this epithelium then does not appear dysplastic. However, if we look, for example, down here in the base of the crypts, and the literature actually talks about the cytological changes being more apparent in the basal aspects of the crypts, as you see here. So, for example, you can see we've got some fairly large nuclei. They're hyperchromatic, they're irregular in size, and that, in fact, is a mitotic figure. So, to the sort of uninitiated, it would be very tempting to suggest that this is dysplastic, because it sort of goes against our sort of histopathological training that we should not ignore these sort of changes. But the convention is, in fact, that we should report this particular change, because we're not seeing it in the superficial epithelium, as indefinite for dysplasia. In other words, We're not saying there's definitive evidence of dysplasia, and we are not saying that there is no dysplasia. So this would be indefinite for dysplasia, and the patient would be followed up according to your usual protocols. So that's a nice case then of Barrett's esophagus, showing you all the changes that are characteristically found.
Oh, thank you, Martin. That was excellent. Some questions. Firstly, a comment. There are a lot of pathognomonic histopathological features of Barrett's. I mean, would you ever make a diagnosis without the presence of intestinal metaplasia?
Chris, yeah, that's an interesting one. I think I certainly myself would like to see intestinal metaplasia, but the literature does say that you can make it without. I think what is important is the site of the biopsy. And I think if you don't see intestinal metaplasia, but one is concerned that, that you're dealing with a Barrett's, if it comes from the right area endoscopically, then I think you're obliged to call it Barrett's.
Is there a difference between the intestinal metaplasia on gastric biopsies from that in the esophagus and Barrett's?
Not really, Chris. They are they're both preneoplastic. So intestinal metaplasia in the stomach should also be regarded with caution because of the propensity to for those patients to progress to dysplasia.
But the point is they look the same.
Yes, they look the same.
And another question from the chat box. Why is it that expert pathologists often downgrade the presence of low-grade dysplasia made by community pathologists? In other words, why do pathologists overread low-grade dysplasia?
Why do they overread?
Well, I mean, the point is it, it seems that experts often downgrade the presence of low-grade.
Yes, I see what you're saying. Yes, I think it's because they see these changes here. So on the screen, for example, as I mentioned to you, I think if somebody's not used to seeing that sort of thing in a Barrett's and recognizing the location, in other words, the basal aspects of the crypts, I think we would overcall that.
Yeah, I think you explained that very nicely. All right, perhaps we could move to the second, your second presentation, which is
right.
of the stomach.
Right. Can you see that?
Yes, beautiful.
Okay, so now we're going to move to the stomach. And this is really just a low power photograph from a website that is quite a useful website, and most histopathologists know it. It's a sort of a pre-seed version of histopathology. But you can see that we've got the mucosa, the submucosa, and the muscularis. And we're going to be spending a bit of time in the mucosa of the stomach. So just going through it logically, this is a photograph from the gastric cardia. And the reason I've put this series of photographs in is really just to alert everybody to the different normal histopathological features in the stomach. So this is in the cardia. And if you look at this here, you can see that you got the gastric glands and the crypts. And you can see that they are separated by collagen. And there's also a smattering of inflammatory cells. There are a few eosinophils. Here in the background, lymphocytes. There's even a plasma cell, for example, down here. And it's important to recognize and to know that if this is from the cardia of the stomach, that is normal, and not to overcall this as a chronic gastritis. So that's a particularly important thing to remember. This here, on the other hand, is the oxyntic mucosa or body type mucosa. And this is normal. And what we've got here is at the top here, we've got the foveola epithelium. And remember that the whole of the surface of the stomach, the whole covering, in fact, the inner aspect, if you were, the luminal aspect of the mucosa is covered by foveola epithelium, which is what you see here. And we'll talk about the gastric crypts later. And here you've got the oxyntic mucosa or body type mucosa. where you've got the pink cells or the parietal cells on the top, and then at the base of that, you've got the basophil cells, the basophilic cells, or the chief cells. And remember that the pink cells or the parietal cells, they secrete acid, whereas the chief cells are responsible for enzyme secretion. But what is important is to note that, in fact, and this is a higher power magnification, you can see, for example, the intermingling. Often you get intermingling, in fact, of the chief cells with the parietal cells. It's not always as well delineated as you saw in the previous slide. But the point I would like to make in this particular photograph is to show you that the glands, the gastric glands here, are closely packed to one another. And in fact, you should see minimal, if any, inflammatory cells between these crypts. So if you see inflammatory cells, and sometimes it's quite difficult. And, you know, if one, for example, here, there could be an argument to be made that there might be a few lymphocytes there. And if that indeed is the situation, then that probably would be regarded as a chronic gastritis, because ideally, you should not actually see any inflammation at all. This, on the other hand, is the gastric antrum, and you can see once again the complete difference. So you can see, just to refresh our minds, that this is the cardia. You can see the irregularity of these glands, their angulation. Notice that they're mucin deplete, at least the mucin secreting as well. There's the body type mucosa, again, high power, and there is the gastric antrum. And here you can see that you've got, once again, mucus-secreting glands with minimal specialized gastric cells. And then these are the foveola pits or gastric pits. And you can see that the gastric pits or the foveola epithelium occupies approximately 50% of the mucosa in the gastric antrum. Once again, notice a relative paucity of lamina propria and also inflammatory cells between the gastric glands. Not quite as closely packed as the oxyntic mucosa, but certainly more closely packed than the cardiac mucosa. And then I just wanted to show you this one, because you will see in many of the histopathology reports, we talk about endocrine cell hypoplasia, particularly in those patients who are receiving protein pump inhibitor therapy. And that's what these cells look like. They look like little lymphocytes, and they are surrounded by cleared cytoplasm, which is actually fixation artifact. So those are typical features then of endocrine cells. Okay, Barbara, over to you.
So our next case is Miss M. She's 49 years old and she resides in Gauteng, currently unemployed. She was admitted to ICU with a drug-induced liver injury, a biliopathy. And she actually presented post-admission with persistent abdominal pain, which was epigastric in nature. She had persistent nausea and no vomiting or diarrhea. On gastroscopy, fundal erythema was seen, and this was suggestive of gastritis.
Right, thanks, Bob. I'm not sure if there are any questions.
No, there are some, but let's wait for the pathology.
Okay, right. So can everybody see that histology?
Perfect.
Great. So what we've got here then, this is a portion of body type mucosa. Why is it body type mucosa? Well, you can see, for example, here that we've got those body type glands. You can see the parietal cells, these cells with the pink cytoplasm, and then you can see the basophilic cells with basophilic cytoplasm. Those are the chief cells. So this is body type mucosa. Now, if everything looked like this, if the whole mucosa looked like that, you can see again that there's really is no expansion of the lamina propria in this particular focus. Don't worry about this here. I want to show you this here. So, excuse me, so that area there would be within normal limits. However, when we go under low power, you can see that that certainly is not the situation. And you can see that there is quite considerable expansion of the lamina propria by this inflammatory infiltrate, which is largely lymphocytic, and we'll go down and have a look at it. And in some areas, it really is quite florid. And you can see this marked expansion of the infiltrate. Now that is completely abnormal because of the site of the biopsy, and also because of the intensity of the inflammatory infiltrate. And you can see that many of these cells, in fact, are lymphocytes. They're mature lymphocytes. As you can see there are a few eosinophils scattered around. Notice the mucin. This is neutral mucin, so if we did a pass on this, it would be pass positive. The Alcium blue would be negative because there's no intestinal metaplasia. And if one looks at this here, and if you look at this area down here, you can see that there's an aggregation of lymphocytes. And all that's missing there is a germinal center. But without the germinal center, we would call this a follicular gastritis, a chronic follicular gastritis. And the evidence is that the patients that have this sort of degree of inflammation, lymphocytic inflammation with follicular gastritis, that they have Helicobacter pylori infection. Now, you haven't quite finished, because in this particular area as well, and when you see this, you need to say to yourself, okay, well, let's look, make sure there's no evidence of Helicobacter pylori. Now we talk about the Sydney classification, and I haven't given you the Sydney classification for the purposes of time, but you remember that we grade the chronic inflammation, the acute inflammation, the Helicobacter pylori, the intestinal metaplasia, and atrophy. And the different categories are absent, mild, moderate, and severe. And if you look here, for example, we can see that there's a gastric crypt there, and neutrophils migrating into this. So this is almost pathognomonic then of Helicobacter pylori infection. You can see that the neutrophils are migrating in, forming a crypt abscess. And in this area here, you've got intraluminal neutrophils. So then it behoves one to go and have a look at the superficial aspect of the mucosa, and there in the mucus layer, you can see the Helicobacter pylori. Curvilinear bacteria. I haven't got an oil lens, but I do think you can see the curvilinear nature of the Helicobacter pylori. You don't need any special stains to diagnose that. And in fact, I often say, one of my sort of favorite sayings is that special stains often make the problem a different color. But if you look there, you can see the curvilinear bacteria of H. pylori. If we look into the actual crypts as well, and I should have put a dot once again in the interests of time, but there were also, for example, if one looks down here, I found one, you can see, for example, just there, and also there, you can see those curvilinear structures, and those are Helicobacter pylori. This here is debris and should be ignored. So if one then looks at immunohistochemistry for H. pylori, and unfortunately, the immunohistochemistry, and I remember years ago actually doing a little project on the ability of special stains to pick up H. pylori. And it really didn't matter, because if the infection was limited, you stood an equal chance of picking it up on H&E or Toll Blue or immunohistochemistry, because the bacteria can be quite scanty. And if we look here, in the crypts, just wait for the picture to build, you can see there, okay, curvilinear structure there, which is consistent with Helicobacter pylori. And the problem is, as I said, often special stains make the problem a different color. And if you look at this here, you can see, for example, there, that I think that there are a couple of bacteria there and there. But this here, I think, is artifactual staining, but probably just contamination. The problem comes in separating out the so-called coccoid forms, but the coccoid forms are really supposed to be found more in an intracellular location rather than actually in the lumen. So there, I think, for example, there's a bacillus there, but this is all. Okay, so that's a nice example then of active chronic Helicobacter pylori gastritis.
Thanks very much, Martin. I mean, we see this so often, and it's wonderful to see the histopathology. A question from the chat box. Same person asking a question, no name, but thank you for the questions. So Martin, we often read these reports saying chronic gastritis, and then the term reactive is added. So is there any specific relevance to the term reactive? Does it differ from an unreactive gastritis? And is there any clinical significance to that?
So, yeah, I think that's, I mean, that's a good question. And I think that, I think those cases that are probably being called a reactive gastritis are probably examples of what we call a chemical gastropathy. In other words, as a result of bowel reflux, where you get disorganization of the mucosa, of the glands, increased fibrosis, a bit of inflammation. And I think there is a danger, in fact, to probably use that as a bit of a dustbin diagnosis, because you make a definitive cause. And I think there, you know, things such as communication, is the CLO test positive, all those sort of things. You need to make sure that the patients haven't got those sort of infections.
Yeah, it's often, I mean, I'm often so impressed how little change in medical management biopsies of the stomach, you know, do, because, I mean, apart from H. pylori infection, it's really a choice of PPI therapy. A question from Mashika Shedi. So she makes a comment on how remarkable it is that the H. pylori are so scanty, and yet they're able to induce such an intense inflammatory response.
Yeah, Mash, I mean, that's also an excellent question as well. And in fact, the reverse is true as well. I've seen cases that have actually been overloaded with H. pylori, you know, in that superficial mucus layer. And I think that's the other important point to make, particularly for the trainees, is that you find the H. pylori in the mucus layer. They don't like any other environment. And I've seen cases, I think probably as recently as the end of last year, where absolutely crammed full of H. pylori and minimal inflammatory changes, and vice versa. I agree.
Perhaps it's virulence factors rather than density that play a role. I think there's another question. Oh, yes, there's another question from Wisdom in Zimbabwe, and that's, is the inflammatory change pathognomonic of H. pylori in the absence of staining? In other words, can you predict H. pylori from the inflammatory change?
So Wisdom also, I think, a good question. I think my sort of understanding from the literature is that if a patient has follicular gastritis, such as that lymphoid infiltrate with aggregates, that's usually due to H. pylori gastritis. I think often we don't really know as histopathologists, you know, what, at least how those patients are treated. So I would ask you, Chris, for example, if you get a diagnosis of a follicular gastritis, certainly, I mean, I make that diagnosis in the absence of H. pylori, and I make the assumption that those patients are then treated for H. pylori, because it may just be a sampling problem.
Well, certainly, and I mean, we do a number of tests to diagnose H. pylori. I mean, I biopsy all stomachs, and I do a bedside test, and urease test, in addition to biopsying and sending off for histology. And there's often no concordance. But, you know, ultimately in clinical practice, a gastritis is a gastritis is a gastritis. And if you know, in the absence of H. pylori infection, it's really your choice of PPI. So, you know, it doesn't really make a big difference clinically to our clinical management. Okay. Obviously, it probably makes a difference to the natural history of the disease process, you know, the propensity to lead on to perhaps gastric atrophy or intestinal metaplasia, etc. But that's a separate issue. Just, you know, chronic gastritis, which we see in nearly every report that we submit, seldom really changes your medical management. So let's move on, Martin. I'm very excited because our timing is good and I want to move to the duodenum. And I know that you've got some exciting stuff there to show us.
Right, so let's have a look now at oops. Right, so can everybody see that?
Perfect.
Great. Okay, so what we have here then, so we're now moving out of the stomach and into the duodenum. And this is, we're going to see a couple of cases. And I think just to show you the normal histology. So what we look for in the duodenum now, typically and pathognomically or anatomically speaking, I should say, or histologically speaking, the important thing to diagnose duodenal tissue is the presence of Brunner's glands. And Brunner's glands are situated in a submucosal location. There you've got the muscularis mucosae there, and then above that you've got the epithelium. And here you can see the villi, the duodenal villi there, and then here you've got the crypts. And it's important to assess the ratio between the length of the villus and the depth of the crypt. And as a rough rule of thumb, there is a wide range which is sort of expressed in the textbooks. And I think sometimes the textbooks really give information that's really a little bit too complicated to be, you know, to be useful from a practicing point of view. And I sort of, in my mind, have in my sort of mind when I'm looking at a duodenal biopsy, is I like to say, well, the normal ratio is 3:1. And in fact, if you look, for example, at this here, you can see that you've probably got 3 times the length of that, maybe a little bit less, 2.5. But you can see that the distance between there and there is of the order of 2.5 to 3 times to 1. And usually if you've got duodenal atrophy, it decreases quite considerably. And I wouldn't be too concerned. Now, the other thing that also happens is that the textbooks always talk about, you know, properly orientated biopsies. And I mean, our experience, as I'm sure everybody else's is that it's seldom that actually happens. And it requires, in fact, that orientation happen at the time of endoscopy. Because what should happen is that the biopsy should be orientated properly onto a portion of paper, for example, so that it sticks to the paper, and then it should be embedded like that, or processed and embedded like that, still on the piece of paper, so that you get proper orientation. And if you don't do that, then in fact your chances of getting orientation like this are extremely limited, in fact, impossible. So we have to make do with what we get, and I think it's relatively easy to assess whether you've got atrophy or not. And of course, the other thing is to take into account the clinical features. All right, so we go then to show you a couple of cases. So Barbara, over to you.
Our next case is Mr. H. He's a 37-year-old gentleman currently unemployed, residing with his mother and sister. He has a background history of vitamin B12 deficiency. He has a short stature. He struggled in school and completed till grade 9. He presented to us with a history of chronic diarrhea for more than 4 years. This has been longstanding. He had significant loss of weight, more than 11 kilograms in the past 3 months, and he complained of abdominal cramps. He actually had a very low calcium of 1.72. He had a low potassium of 2.1, and albumin was 20. Our thoughts when he also had iron deficiency anemia with an HB of 7.6. He had signs and symptoms that we thought were in keeping with a possible autoimmune polyglandular disease, which we worked him up for, but most of his antibodies were positive at the time we saw him, and his ANA was negative too. When he did his gastroscopy, we saw that he had extensive esophageal candidiasis, and there was evident inflammation in his duodenum. Biopsies were taken. Later in the workup, we did immunoglobulins, and his IgA, IgG, and IgM were very low. So we're working him up for a common variable immunodeficiency currently. And we are thinking that this might be enteropathy associated with this disease. He is still being worked up though.
Right, thanks, Barbara. So let's show you this. Right, you should be able to see a histology there.
Yeah.
Great. All right, so this is the duodenal biopsy. So once again, you've taken a photograph of what the normal duodenum looks like in your occipital cortex. And you can see, for example, by just comparing those two images, the one that you've taken a short while ago and this one, you can see that there's a considerable difference. Now, in this particular instance, unfortunately, there are no Brunner's glands. So you can't be absolutely dogmatic and say that this is duodenum. So you have to take an element of trust in the endoscopy findings. So what we've got here, then, you can see straight away that the cryptovillus ratio is abnormal. So you've got architectural change, which is present in this particular biopsy. For example, if you look here, difficult really to be certain exactly what is happening from the point of view of the cryptovillus ratio. I would suggest that it's probably 1-to-1 or even less. It looks as though it may be even 0.5 to 1. So there's considerable atrophic change. There's also a large lymphoid follicle there in the lamina propria, which is a normal finding. And then elsewhere in the biopsy, so this area here, for example, is better orientated. And you can see that there's almost complete flattening, not total flattening, but almost complete flattening. And if you look at this, the first thing that you would think of would be celiac disease. However, the features of celiac disease, I think most of you will recognize. So you go down, you say, oh, well, I think this is probably a celiac. He's got diarrhea, and then to your surprise, you see that there are neutrophils. And these are neutrophils which are present in the epithelium and in the mucosa. There, for example, there's another area there where there are large numbers of neutrophils. And you can see the neutrophils, for example, really well demonstrated in this crypt here. Lots of neutrophils migrating into that epithelium. And then in this area here, again, large numbers of neutrophils migrating into the epithelium. And as you know, you shouldn't get neutrophils in celiac disease. So if one looks, for example, at Odds's textbook of gastrointestinal pathology, you'll see that this entity actually fits into the category of what we call active chronic duodenitis. And that's what we called this. This is not a celiac disease. And typically what happens with active chronic duodenitis is you do get atrophy of the mucosa. Yeah, so that's a good example. So what I'd like you to do then is just to remember the photograph in your mind, park that away in your mind of these neutrophils and then we'll discuss the next case.
Can we ask, there's some questions about this case, Martin.
Yeah, sure.
So Tim, will you unmute and perhaps ask your question regarding the Epex syndrome, which is, I think, a syndrome that pediatricians see. Tim, are you there?
Yes, can you hear me?
Fantastic. Prof? Nice to see you, Tim. Welcome. So let us hear about Epex and
see, sometimes you do need
pediatricians.
Yeah,
tell us.
It just rang a bell for me that Epex syndrome stands for immune dysregulation, polyendocrinopathy, and enteropathy, X-linked. So he's a boy. He's got endocrinopathy, he's got enteropathy, and he's got immune dysfunction. So all of those would fit. I don't know terribly much about it. It's a very rare syndrome. They usually present early in life, and it's FOXP3 mutation. It might be interesting to consider.
Thanks, Tim. So, Martin, just to confirm again, it's not celiac because?
Because of the neutrophils in the epithelium.
Right. Okay, excellent. And the second question is, how many eosinophils do you need to make a diagnosis of eosinophilic gastroenteropathy?
I think if you ask as many histopathologists, you get as many answers. You know, the figures vary from 20 to 50 per high power field. Yeah, I think that's a difficult one, Chris. I think one has to be guided by the clinical features, what you see obviously under the microscope, whether there's an accompanying eosinophilia. Yeah, but they vary. I mean, if you take, for example, if you take eosinophilic esophagitis, there you get the typical sort of the rugae in the esophagus that you're supposed to see with that entity.
Okay, excellent. Thanks for that, Tim, too. So we'll chase that syndrome up. Barbara, you'll do the genetic analysis and come back to us. Okay, Martin, have we got another case?
Yeah, Barbara?
Yes. Okay, our next case is Miss K. She's a 21-year-old lady from Benoni, currently a student. She has a background family history of her mom being a post-transplant patient for autoimmune hepatitis. She presented with vague symptoms of generalized malaise and fatigue and intermittent episodes of diarrhea. We did her iron studies, and it confirmed iron deficiency anemia. On her bloods, she had an anti-TTG that was positive, an ANA that was 1:320 on titer, and we did a gastroscopy and did particularly duodenal biopsies.
Great, thanks, Barbara. Right, can you see that histology?
Yes,
Chris?
we can.
Okay,
Yes,
okay.
yes, perfect. Sorry.
Okay, right. So let's just have a quick look here. So here we've got small bowel mucosa or duodenal mucosa, as you can see, and then just at the edge of this particular biopsy, one can see Brunner's glands under lower power magnification. You see Brunner's glands there. You've got the muscularis there. So that tells you that you're definitely in the duodenum. And if we look at the overall architecture, we remember our photograph that we took of the normal duodenum, and you can see that there is a flattening of the villi. And you can see there's probably a 1-to-1 ratio. That's the crypt base there. That is the top of the crypt. There's the base there. So between there and there, and there and there is about 1-to-1. So you've definitely got atrophic changes. It is variable. For example, here it looks as though, in fact, it's far less than 1-to-1. And then as we move over here, there is a suggestion that, in fact, that there is complete atrophy. So we know then that there is duodenal atrophy, and you go down. You must obviously, although I said that that particular patient was had active chronic duodenitis, the previous one, you must also make sure that you haven't got other infections such as Giardia, because Giardia can also cause mucosal atrophy. And it's an infection which is found in this part of the world and also in people who travel. So you mustn't forget about Giardia. And that can be quite tricky to see sometimes. So looking at this then, you go down and we have a look, and we see that the lamina propria does show focal expansion by a mononuclear component. When we actually have a look closer look at that, you can see that we have large numbers of lymphocytes that are migrating into the epithelium. And you can see all these lymphocytes, and you're supposed to count 5 villi with 100 epithelial cells, if I remember correctly, and count the number of lymphocytes per 100 epithelial cells. And you should not have more than, I think it's 20, if I remember correctly, per 100 epithelial cells. But in this particular instance, you can see that if you count these, that we've got way more than the 20 lymphocytes per 100 epithelial cells. And in fact, in some areas, it's a little bit poorly orientated. But for example, there where the orientation is better, you can see that you've probably, I would say that you've got at least 1 lymphocyte for every epithelial cell, because if you look there, for example, 1, 2, 3, 4, 5, 6, 7, 8, 8 lymphocytes associated with 3 or 4 epithelial cells, enterocytes. Lots of plasma cells in the underlying lamina propria. And then when we look at the CD3, because those are the cells that should be there in a patient with celiac disease. So here, you've all this brown staining, those represent CD3 positive T lymphocytes. So you can see that the ratio is at least 1-to-1. So this is a classic example then of celiac disease, and using the Marsh grading, I think we called this a Marsh B and a Marsh C. So that's that case, Barbara. Chris?
Thanks very much. Do you have more, Barbara?
No, we've got one more.
Okay, great. We're on 5:30, but far ahead.
Okay, Barbara. You might be on mute, Barbara.
Apologies, I was on mute. Sorry, Mrs. W is a 74-year-old lady. She's a pensioner from Johannesburg. She has a background history of hypertension and diabetes, and she was diagnosed with hyperparathyroid in 2020. She had a parathyroidectomy and 2 adenomas that were found. Now presented about a year later with refractory hypocalcemia. She had significant loss of weight over the past 4 months. Also, osteoporosis, osteoarthritis with multiple surgeries to her knees and hips in terms of replacement. Her endocrinologist was working her up for Men's syndrome, but was worried that there might be a PTH RP secreting tumor that maybe find neuroendocrine tumors found gastrically. So sent her to us for a biopsy investigation with the G-scope. So gastroscope, we found her to have duodenal nodules. There were multiple nodules in D2 in particularly, and histo was taken.
Thanks, Barbara.
Thanks.
Right, you should see histology there. Okay, can you see that, Barbara?
Yes,
Yeah.
we can.
Okay, so this is a nice duodenal biopsy. And here you can see Brunner's glands, you can see the mucosa. And this also illustrates the point that I was making about the embedding and really just making do with what we see. So if you have a look here, for example, you could be tempted to suggest that there's an element of atrophy in this area of the mucosa. But I think that if one looks at that, and we will just now, you'll see that there's no real reason for any atrophic change. Whereas on the right-hand side of the screen here, you can see well-formed villi, and you can see very nicely demonstrated the 3-to-1 ratio between the villus height and the crypt depth. So there's no evidence of atrophy here. And of course, bearing in mind that we weren't really looking for atrophic changes. What was seen at endoscopy was in fact nodules, and we were investigating for possible MEN syndrome and endocrine cell hypoplasia or endocrine tumors. But instead, what we've got is something which is fairly common, and that is we've got these duodenal glands, at least these Brunner's glands, here in the submucosa. Those are fine, but then when we look above the mucosa, at least above the muscularis mucosa, there you see that we've got Brunner's glands on both sides. And this is a very good example of Brunner's glands hypoplasia. And you can see that we've got more there. And it typically causes Brunner gland hypoplasia typically causes nodules in the duodenum, which can be concerning. They're quite a frequent finding, more Brunner's glands there. And it can be difficult to separate out Brunner gland hypoplasia from Brunner gland adenomas. You also get those as well that also cause a nodular appearance to the stomach. But you can see, for example, just as we go through this, that the Brunner's glands, so the section is not well represented in terms of muscularis, which is sitting in this void here. But you can see this intermingling of the Brunner's glands with the duodenal crypts. So quite extensive and a great example. Thanks,
Clinical significance, Martin?
The significance really just to recognize what it is.
Are there hematomas?
No, they're not hematomas. Yeah, it's a good question. No, they're not really hematomas. They're just hypoplasias.
So it hasn't sorted out the clinical issue here, so you'll have to keep looking. Question to Bob, what was the reason for doing a chromogranin A? Well, you were looking for a neuroendocrine tumor, most likely, which was normal, by the way, huh?
It was normal, yes.
Yeah. All right, so that didn't help with the diagnosis, so you'll keep looking.
Yes.
Okay, well, look, it is time. So, Martin, any final comments or?
No, thanks, Barbara. You presented the history very nicely and succinctly, and I think we managed to get through half a dozen very interesting cases. Thank you. Thanks, everyone. Thanks, Chris.
Yeah, well, thank you very much, Martin, and thank you very much to Barbara, who's a GI fellow at WITS. It was a wonderful potpourri of cases introducing luminal GI pathology. So in our next pathology session, we'll be extending this to the colon and obviously concentrate on polyps. But the very big and important sub-Saharan issue is really inflammatory bowel disease. So we'll be spending quite a lot of time differentiating inflammatory bowel diseases from TB, and particularly the histological features. So that's something to look forward to. Next week, we have an gecko endoscopy session. And also in the next month, GASA, our association, will be teaming up with AU-NEPAD, the New England Partnership, which is the developmental agency of the African Union, to kind of do some presentations on how we can influence policy in sub-Saharan Africa. So that will be an extraordinary meeting of GECKO, and we'll be advertising that, and you're all encouraged and welcome to attend. So it remains for me to thank you, the speakers, thank the audience, thank Project ECHO for this wonderful teaching platform, ECHO India because for their help with the logistics. Feedback is always available. Remember that these recordings are available on the Gastro Foundation website. Really thank you to Cheryl and Karen who help us with the running of these programs, and also to the sponsors, Takeda, Aquino, Amgen, Equity, and Aspen. And that is all we have for today. So thank you very much once again. Good afternoon, good night, stay safe, and look forward to welcoming you back in a week's time. Thank you very much.